So hi, and welcome to day 3 of EULAR 2022. My name is Douglas Veale. In this podcast, I would like to review what I felt were some of the key sessions and papers of interest from the CSF perspective. There's some terrific sessions today covering cardiovascular and VTE safety from both a clinical trial and a registry data perspective, as well as some informative data from 2 new potential therapeutics in psoriatic arthritis, to name just a few. I hope you find this broad podcast and review of data both interesting and informative. Before we dive into some of the more specific details of therapies and data from today, I just wanted to highlight 2 sessions. In the first, Garcia Diaz and colleagues have used a systematic review and Delphi survey to establish practical and evidence-based nursing recommendations for the management of people with RA undergoing treatments with JAK inhibitors. In the second session of general interest, Simons et al. Quantified first-degree relatives' preferences for preventative treatments for RA. So if we take a look, first of all, at the recommendations for nurses in the management of RA, some of these, I would say, are very intuitive. So for instance, before starting treatment with a JAK inhibitor, it should be confirmed that the patient has no contraindications. The patient's efficacy and outcome expectations for the drug should also be explored, and those that need to be adjusted can then be so. It should be indicated that double dose should not be taken if one is missed. So many of these recommendations are certainly common sense. As with other DMARDs, the patient should be instructed that close management will follow. In particular, the use of contraception and discontinuation of the drug is recommended in the case of gestational desire or unplanned pregnancy. It is also recommended to explain the warning signs of infection. So for instance, fever, rash, blisters, burning pain in the ribs, itching when urinating, productive cough, diarrhea in the case of a GI infection, or pus-filled wounds in the case of advanced skin infection. It's recommended to instruct the patient on preventative measures for infectious diseases, so that particularly, as we have heard over the last 2 years, hand hygiene, washing of hands before and after contamination or potential contact. Dental hygiene is critically important, as is vaccination against common germs in immunocompromised persons and in relation to shingles. Cardiovascular risk factors should be monitored and the patient trained for signs of thrombosis. So for instance, leg swelling or a blood clot, heart failure, and also ischemic heart disease. There should be extra close monitoring of elderly patients, particularly if there's cardiovascular risk or infection risk identified. And the emphasis on adherence to therapy is also important as far as the JAK inhibitors is concerned. Before surgery, it's recommended that discontinuation of JAK inhibitors should be scheduled depending on the type of surgery and the coexisting comorbidities. So overall, these recommendations will allow a practical approach to the management of JAK inhibitors by nurses, and hopefully they will enjoy an adequate consensus amongst the potential endpoint users. Simons et al. Really focused on preferences for treatment to prevent rheumatoid arthritis. And it looked at a survey, essentially, of first-degree relatives in both the UK and Germany. And they wanted to quantify the first-degree relatives' preferences for such treatments. So they surveyed over 350 people, and the analysis actually took the form of two-class latent class analysis. This was used to estimate the preferences and to calculate the relative importance of treatment attributes and also predicted uptake. So the treatment effectiveness was the most important attribute in both classes. And the importance of other attributes differed between the classes. So the method and the frequency of treatment administration was more important in the class 2, whereas the risk of mild side effects only impacted treatment choice in the class 1. So the conclusion was that effective preventative treatments for RA acceptable to first-degree relatives asked to assume a 60% chance of developing RA. Now, in terms of RA safety, again, the focus was mainly on cardiovascular and venous thromboembolic events. And currently, these are at the forefront of safety when it comes to treatment of RA with the JAK inhibitors. To this end, I've selected 3 sessions of interest. The first is that from Maxime Dugados and colleagues, which looks at the impact of baseline cardiovascular risk on the incidence of major adverse cardiovascular events in the tofacitinib RA clinical program. The others are from Charles Schoeman and colleagues and Zoltan Seskanec, which provided data on the risk of VTE in patients with RA treated with tofacitinib. And finally then from Kevin Winthrop, who also provided safety data on the results of an integrated safety analysis update from the filgotinib program in RA patients. I mention also of interest Breedemeyer and colleagues who actually have a poster evaluating the association of concomitant use of antimalarials with the overall safety and survival of treatment course among patients receiving one or indeed multiple courses of biologic or targeted synthetic DMARDs. So if we look first of all at the impact of baseline cardiovascular risk on the incidence of major adverse cardiovascular events in the tofacitinib RA clinical program, this analyzed data from 21 phase 1 to 3B and 4 studies and 2 long-term extension studies. So over 7,900 patients. And the data was pooled and analyzed as 2 cohorts. 1, the overall cohort, and 2, a cardiovascular risk enriched cohort, which identified patients over the age of 50 years and those with more, 1 or more additional cardiovascular risk factor. So the key results from this study showed that the MACE ARs were lower in the overall cohort versus the cardiovascular risk enriched cohort. So you can see the data there, 0.38 and 0.37 in the average overall cohort versus 0.72 and 0.67 relative risk, respectively, in the cardiovascular risk enriched cohort, which is probably not surprising, but it is important to see that result from this large analysis. In the adjudicated MACE cases, these most commonly occurred in patients with a history of cardiovascular disease or indeed a high 10-year risk of MACE at baseline. So overall, these results are consistent with the results of the oral surveillance study, but should be interpreted with caution due to the low patient years of exposure in some of the patient groups, but it does seem consistent overall. In the next study from the group of Zoltan Seskanec, biomarkers to predict risk of VTE in patients with rheumatoid arthritis receiving tofacitinib or indeed TNF inhibitors was explored in a post hoc analysis from post-authorization safety data. The study results showed that baseline characteristics were generally similar to those with and without VTE and in between treatment groups, and no biomarker showed a clear mechanistic association with the increased risk of VTE in patients treated with tofacitinib or indeed a TNF inhibitor. And no demonstration of adequate performance of prognostic use in patients with RA. So moving on to the next study from Charles Showman and colleagues, the risk of VTE events in patients with rheumatoid arthritis aged 50 years or over, with one or more cardiovascular risk factors, essentially from the phase 3b and 4 studies looking at tofacitinib versus TNF inhibitors. They analyzed over 1,400 patients in 3 groups receiving tofacitinib 5 milligrams BD, 10 milligrams BD, or a TNF inhibitor, respectively. And essentially, the IRs were calculated for adjudicated VTE, DVT, and PE. The key results from this study showed generally across 6-month intervals over a 54-month or greater period that the events were numerically higher with both tofacitinib doses versus TNF inhibitors, and with tofacitinib 10 milligrams versus 5 milligrams. So again, I think this is consistent with the data that is out there, that the higher risk groups and on the higher risk of a higher dose of tofacitinib were at a slightly higher risk over time. And these IRs were consistent over time. Across treatments, VTE, DVT, and PEs were higher in patients with versus those without a history of VTE, which is again, I think, consistent with the existing data that is out there. So the data from Kevin Winthrop and colleagues looking at the integrated safety analysis update for filgotinib in patients with moderate to severe active rheumatoid arthritis receiving treatment over a median of 2.2 years. They analyzed over 3,600 patients receiving either filgotinib 200 or filgotinib 100 milligram doses for over 8,000 patient years exposure. And the key findings here really were that there was adverse effects were higher with the filgotinib 100 than 200 dose, and the deaths from IRs related to adverse events were 0.5 and 0.3 for filgotinib 200 and filgotinib 100. And the incidence of infections and serious infections were numerically greater for filgotinib 100 versus filgotinib 200, whereas the adverse events and other adverse events were comparable between doses. The adverse events tended to decrease since the previous update, except for those associated with venous thromboembolism and malignancies. So with a 1-year additional exposure since the 2020 report, filgotinib continues to be well tolerated with no new safety concerns emerging. And the adverse events, including deaths and adverse events, remain stable or decreased since the 2020 report, except for a slight increase in non-melanoma skin cancers and malignancies excluding non-melanoma skin cancers. So we all are very familiar with the importance of real-world registry data to support the clinical trial data, because these patients obviously are a little less well selected, and therefore they represent the patients in our clinics to a greater or lesser extent. And certainly it may inform clinical practice, therefore, to a greater degree. And with this in mind, I've selected 2 papers from today's sessions looking at JAK-inhibitors in RA. The first is from Nam et al., looking at the discontinuation due to adverse events in patients on JAK-inhibitors. And the second is from Rusin Witrand and colleagues, looking at major cardiovascular and thromboembolic events in relation to safety reports between rheumatoid arthritis patients treated with JAK inhibitors versus anti-TNF therapies. So if we look at the report from Nam et al. First, the objective of this study was to assess the safety of JAK inhibitors compared to other biologic agents in RA patients in a real-world population. And this essentially was the evaluation of treatment discontinuation for adverse events in a pooled patient database from 16 national RA registries across Europe, Canada, Turkey, and Israel. And the key results were a similar crude incidence rate of treatment discontinuation due to adverse events between JAK inhibitors and TNF inhibitors. But they were less in the JAK inhibitors compared to OMA. Fully adjusted HR treatment stopped for adverse events was also similar in JAK inhibitors versus TNF inhibitors and in JAK inhibitors versus the OMA. So after adjusting for potential confounders, the rate of treatment discontinuation due to adverse events was comparable really across the JAK inhibitors and the OMA or the TNF inhibitor treated patients. So in the study from Roos and Wichand and colleagues, who compared the major cardiovascular and thromboembolic events in safety reports between rheumatoid arthritis patients treated with JAK inhibitors versus anti-TNF therapies. And this essentially gives the results from the VigiBase database, which is a WHO global ICSR database, looking at over 11 million reports. They compared the report of MACE events and VTEs with JAK inhibitors versus TNF inhibitors. So there were 611 or 1.6 percentage points of reports in JAK inhibitor treated patients versus 3,240 or 1.4 percentage points in TNF treated patients with MACE events. Then in the VTE, there was 341 or 0.9% in the JAK inhibitor treated group and 571 or 0.2% in the TNF treated patients with VTE. So you can see there's slightly higher percentage points in the JAK inhibitor treated patients getting VTE compared to the TNFI treated patients, but slightly higher numbers, and this reflects the higher numbers of patients receiving TNF inhibitors on the database. When they did a disproportionality analysis, this identified an increased risk of reporting VTE events in JAK inhibitor treated patients compared to anti-TNF treated patients. So that is interesting from a huge database globally, looking at the event rates and the risks of the MACE and VTE adverse events in these patients in the real world. So RA efficacy, of course, is important, not discussed in any detail in this podcast, but I would recommend the oral session, which is entitled Comparison of the Effect of Different Janus Kinase Inhibitors on Activation, Function, and Property of NK Cells to Control Cancer Cell Lines Proliferation, an ex vivo and an in vitro study presented by Mudek et al. And this provides some thoughtful insights into the phenotypic and functional impact of JAK inhibitors on NK cells. So you can look at that in your own time. Now let's switch our focus to psoriatic arthritis, or PsA, from RA, and two sessions of interest today which focused on new data in PsA. The first from Merola and colleagues, in which they presented a 16-week efficacy and safety data on bimekizumab B complete phase 3 study. And then from Behrens et al., which presented 16-week data again, but in this time with a focus on the results from a phase 2 study of izokibep in psoriatic arthritis. otherwise known as ABY035. In addition, in psoriatic arthritis, Zabotti et al. Provided results from machine learning analysis of minimal disease activity response patterns in bio-naive treated patients with guselkumab, and D'Agostino et al. Investigate the value of various reduced joint sets to predict the validated GLOS score. So in the first study from Marola and colleagues looking at bimekizumab, this was a 16-week pivotal phase 3 study looking at the efficacy and safety of bimekizumab in over 390 patients, nearly 400 patients in the B-Complete study. And the primary endpoint in this study was quite high. It was ACR 50 at week 16. And the primary endpoint was met in the bimekizumab treated patients. 43.4% patients achieved an ACR 50 compared to 6.8% of placebo. And this was highly statistically significant. There was also a rapid separation from placebo as early as week 4 in comparison to the placebo-treated patients. Interestingly, all ranked secondary endpoints were also met with a high degree of statistical significance. So bimekizumab, which is a dual inhibitor of IL-17A and IL-17F in patients with active psoriatic arthritis with prior inadequate TNF inhibitor response, resulted in rapid, clinically relevant, and statistically significant improvements in efficacy outcomes compared to placebo. So the next study of izokibep in patients with active psoriatic arthritis, this is an earlier study, a phase 2 study, again with this high bar of an ACR 50 endpoint at week 16, looked at the efficacy, safety, and pharmacokinetics and immunogenicity of izokibep compared to placebo. And at week 16, the confirmatory primary endpoint of ACR 50 response rate was met, again, highly significant with p-level of 0.0003. The ACR 50 response rate was 52% in the high dose treatment group, that's 80 milligrams, compared to the lower dose group of 48% in the 40 milligram treatment group, and then 13% in the placebo group. Interesting, there was no serious or severe adverse events found during the first treatment period in this phase 2 study. So that's, I think, hopeful data for the future, and I'm sure will lead to further studies in this agent. The next study is that from Zabotti et al. And this group, as I said, used machine learning to identify the minimal disease activity response patterns in bio-naive treated patients. And they looked at the minimal disease activity domains over time to see can they find potential baseline response predictors. And they looked at a cohort of over 570 patients taken from a study essentially of guselkumab in different doses across the Discover 1 and 2 clinical trial program. And they used an unsupervised machine learning time series clustering algorithm. And through week 52, so after 1 year, the MDA response rates were highest in the third cluster and lowest in the fourth cluster. At the same time, all clusters showed continuous improvement in mean values across all minimal disease activity domains. So all clusters showed some response, but the machine learning identified a sort of a high responder group, a high responder cluster, and a low responder cluster. Interestingly, clusters 1, 2, and 4 all met the PASI threshold for skin responses, and they showed a substantial reduction in swollen joint counts while other domains varied. In the cluster 1 and 2, there was improvement in clinical measures that paralleled that of the third cluster. However, the patient-reported outcomes appeared to take longer to resolve. So I think this is an example of machine learning, which is being applied more and more now to clinical trial data and indeed registry data to see, can we predict using machine learning and algorithms those patients who are going to respond to treatment before we actually initiate that treatment. This is from Mara D'Agostino and her colleagues, and this was looking at a slightly different approach. So they were looking at data from the ultimate study, which is a 52-week study with a 12-week double-blind placebo-control period, followed by a 12-week open-label treatment and a 6-month open-label extension period. And they essentially investigated the value of various reduced joint sets to predict the validated global OMERACT EULAR synovitis score in response to secukinumab in patients with active psoriatic arthritis. So there were 5 models established with reduced pairs of joint sets, 9 to 13 pairs, and all 5 models of reduced joint sets showed high correlation with the global synovitis score, with an R value, an R squared value of around 0.95. So that really shows an extremely high correlation, almost perfect correlation, I would say. And so all models of reduced joint sets for power Doppler ultrasound detected synovitis predicted the synovitis score well. So that bodes, I think, very well. It's good validation for power Doppler ultrasound detected synovitis in the assessment of psoriatic arthritis patients in clinical trials. So with that, we've had another busy day at EULAR 2022, and I hope you'll agree we've had some great cytokine signaling presentations there. I hope you've enjoyed this roundup of day 3. If you haven't already done so, you can download the EULAR 2022 highlights brochure from cytokinesignaling.com to see the abstracts that we've selected for you for the whole of the Congress, along with our top picks that we've just reviewed here. So please join me again tomorrow as I discuss highlights from the final day of the Congress. And until then, we'll say adieu.